Collaborative, and I'd like to welcome all of you to our July 31st webinar, Patients and Families as Partners in Care Delivery Transformation. We are thrilled to have so many folks joining us today. We've got over 300 people signed up, and so we so appreciate your participation. As you saw advertised, today's webinar is going to highlight the work that the National Partnership for Women and Families is doing around various patient-centered delivery models. And then they're going to talk to us about how the organization is helping to build partnerships with patients and families to improve health outcomes. So I'm going to introduce in just one moment Jennifer Sweeney, Allison Shippey, and Mark Savage, all here today from the National Partnership. But before I do that, I'm just going to have a few announcements and housekeeping items. The first is, as many of you are aware, we have an annual fall conference. It's a big one. It's exciting. There's all kinds of opportunities for learning and networking. We have just opened up registration, and so we are hoping that you all go to our website and get signed up. Our patient-centered primary care at the heart of value and quality is the theme this year, and the early bird rate ends September 26th. The conference itself is from November 12th through the 14th. Secondly, wanted to let you know at that conference we are going to be having our first ever awards dinner, and there we're going to be honoring the special contributions of 3 leaders, all dedicated to primary care and to patients, starting with Deborah Ness, who, as many of you know, is actually the president of the National Partnership for Women and Families, and a dear friend of mine from back in the day, Dr. Ted Winslow from Ohio, and then the Southeast Texas Medical Associates, Dr. James Hawley, who he also goes by Larry. So we're hoping that you'll join us for the meeting and join us for the celebration. One quick other bit of news, we relaunched our patient-centered primary care training program database today. So if all of you have not seen that, please do go to our website. We've added 31 more programs that are from academic and training institutions. We've added these to the original 100 that we launched last December. We highlight this in our newsletter that just came out this afternoon. And you can filter and sort by all kinds of information, location, education, profession, teaching style, etc. So please go to our website. And then finally, just a housekeeping, as I think many of you know, we use webinar software to ask our questions and provide comments in this webinar today. And so if you want to do that, please submit your questions in writing using the drop-down question box that should be on your screen. And then during the last 15 minutes of today's presentation, we'll open it up for question and audience from all of you. And our Chief Operating Officer, Amy Gibson, will facilitate that with our guests today. Also, as I think many of you are well aware, we make all of our slides and the recorded presentation available on our website about 24 hours after the webinar is done. So with that, it's my pleasure to introduce our speakers. To save time, I'm just going to mention a few key highlights from the bios of each of our speakers. We do have full bios on our tremendously talented speakers, and so please do go to our website and see more information if you're interested in learning more about Jennifer, Allison, and Mark. With that, I'm going to start with Jennifer. She is a vice president with the National Partnership for Women and Families, and she directs their patient and family engagement portfolio. So she works on building effective partnerships at the grassroots level, and she does that with consumer advocates and patients and families and healthcare clinicians and staff, all with the goal of achieving the triple aim. So Jennifer, welcome. Next, we have Allison Shippey, who's the Associate Director with the Consumer Purchaser Alliance. So she, too, is at the National Partnership. She serves as the Associate Director, and that particular alliance is a collaboration of leading consumer, employers, and labor groups working together to promote the use of performance measurement, that measurement being used to help inform consumers around value-based purchasing and payment. And then finally, Mark Savage, who serves as the Director of Health Information Technology, Policy, and Programs. for the partnership. His work is focused on policy development for patients and families, largely focused on things like meaningful use and other related initiatives at the Office for the National Coordinators, also with CMS as well as the White House. So with that, I again welcome everyone who's joined our webinar. We're thrilled to have our terrific colleagues at the National Partnership here with us today, and I'm going to go ahead and turn it over to them.
Great. Thank you, Marcy. This is Jennifer Sweeney, and I'd also like to thank PCPCC for hosting this webinar on what we think is a very important topic of partnering with patients, families, and advocates to transform care. So I'm going to hopefully, yes, it worked, advance the slide. So a little bit about the National Partnership. We've been a member of PCPCC for a long time, so I know that there are probably many folks on the phone who are familiar with our organization. So I'll just briefly say, by way of introduction, that the National Partnership is a nonprofit consumer organization. We're based in Washington, D.C., and we have a long history, more than 40 years actually, of working to improve life for women and families. We have a very diverse and extensive healthcare portfolio, and today my colleagues and I are going to present on 3 specific areas of that portfolio. I'll be talking about patient and family engagement, Allison will talk about quality measurement and public reporting, and then Mark will talk about health information technology. The National Partnership also leads several health coalitions, and they're made up of consumer, patient, and labor organizations. They work on national, state, and local levels, and essentially what they're doing is advocating for meaningful changes in healthcare delivery. One of those coalitions is one that I and my team lead. It's called the Campaign for Better Care. And later in the presentation, you'll hear from Mark, who will discuss the coalition that his team leads, and it's called the Consumer Partnership for eHealth. So because before I go on any further, I just want to point out there are 3 of us presenting on today's webinar, and we want to leave some time for questions at the end. So really what we're going to do today is provide a high-level overview of our work, but at the last slide, you'll see that we've included our contact information, and we'd really encourage you all to reach out to us, give us a call, shoot us an email. We'd be happy to talk with you in detail about the great work that we do. We love the work that we do, and we'd love to talk with you about possible ways that we might collaborate. Okay, so with that introduction, I'm going to take you back to about 2009 and 2010, which is when the National Partnership worked to influence policy with the goal of advancing patient and family engagement and partnerships with patient and family caregivers. And we did that by mobilizing our Campaign for Better Care Coalition during the drafting of the Affordable Care Act. And we worked with key policymakers, healthcare providers, and industry stakeholders. And what we were trying to do was really raise their awareness about the importance of ensuring that the legislation reflected the kinds of care patients and families really need and want. And then we led what we often refer to here at our organization, a constant drumbeat of consumer advocacy. We did that with our coalition partners with the goal of building patient and family-centered criteria and accountability metrics into that legislation, and then later into the regulations and the program requirements and the evaluation criteria for new models of care that were coming out of the CMMI. And we actually had a lot of success. So a couple of the things that I want to point out that new models are accountable for because of that drumbeat of advocacy are things like engaging patients and families in care planning, in goal setting, and in shared decision making. Being accountable for coordination of care and for communication and information sharing with patient and family caregivers, for patient access to information, and very importantly, including patients and consumers in governance and delivery redesign. And in all of these models, there's also a focus on patient and caregiver experience. So that's just a little bit of history about the policy and advocacy work we did during the Affordable Care Act process. So once we were successful in incorporating these patient-centered criteria into the Affordable Care Act and into the accountability metrics, we then began to work directly with those delivery and quality improvement models to support what we call collaborative consumer engagement. And that's the work that my team and I continue to do today with a variety of models. And I'll tell you a little bit about those models. So we're working with the Comprehensive Primary Care Initiative. Some of you may be a part of that initiative or be familiar with it. It's comprised of 500 practices in 7 regions around the country with the aim of coordinating primary care for Medicare patients. The second is the Partnership for Patients Initiative. It's about 4,000 hospitals around the country. Their goals are to reduce hospital-acquired infections and readmissions. And then there's the Pioneer ACOs, and there are about 23 of them. They're in multiple states around the country, and they're coordinating care for patients across settings. Our goal in working with all of these models is to help provide them with the content expertise, guidance, and technical support to work collaboratively with patients, with family caregivers, consumers, and advocates to achieve each of those initiatives' specific program goals. And our work with each of these initiatives is a little bit different. So, for example, in the CPCI project, we're supporting the practices in building effective patient and family advisory councils. They then work with those councils to achieve the CPCI goals, things like shared decision-making for specific conditions, improving access, launching a patient portal. With the Partnership for Patients hospitals, in some cases we're doing something very similar to CPCI. We're helping them build and launch effective patient and family advisory councils. But in other cases, the hospitals have decided that they don't want a formal infrastructure per se, like a council, but they do want to embed patients and family caregivers and advocates and consumers on quality work groups, or they want to include them in lean events. We help them do that. We have an expertise in recruiting and engaging patients and families, so we help the hospitals find the right patients. We get both the patients and providers and staff up to speed on how to collaborate across stakeholder groups, and we facilitate relationship building and successful engagement. With the pioneers, what we've helped them do is, some of you all may know that they are mandated to include both a consumer and a consumer advocate on their governing board. So we've helped them find appropriate representatives for those governing bodies, and then we've developed tools and resources to both bring those representatives up to speed on content and build their capacity to engage effectively, but have also helped the ACOs think through how can they best engage these representatives beyond governance and also include additional representatives, whether that be in beneficiary redesign or care delivery processes. So with all of our collaborative consumer engagement work, it's important to point out that we hold this foundational belief that partnering with patients and families is not an activity. A lot of times we'll hear people talk about engaging patients and families as sort of like an additional thing, an additional burden they have to do. And really in our minds, engaging with patients and families or partnering with them is really more of a strategy. It's a strategy for achieving individual program goals like those of the 3 models that I just talked about. But at the end of the day, it's also a strategy for moving our overall healthcare system to be more patient and family centered. And in our minds, this strategy is really different from what's been deployed in healthcare in the past. What we've seen in the past with healthcare is that the system does things to and for patients with the aim of improving delivery and experiences of care and reducing costs. But collaborative consumer engagement, as we envision it and as we use it in these new models, involves a real shift in culture in which healthcare organizations really recognize that patients and families and consumers and advocates have unique insights, they have unique perspectives and experiences that can inform healthcare and help it transform. So, in our mind, this requires a real shift in thinking, and it requires a willingness to share leadership with patients and families, and really an openness to assessing, what does care delivery look like today? How can we together establish joint goals with patients and families? And I think most importantly, it requires an understanding that once those goals have been established, consumer stakeholders will play a key role in the redesign implementation and the evaluation processes, really as equal partners. And I'll just give one very brief example. I mentioned earlier in the presentation about patient experience, and that's really been elevated over the last 7 years as a real key ingredient for healthcare organizations to look at. And some of the healthcare organizations that we've talked with, I think they've really come to recognize that in the past, they themselves have looked at the patient experience data and then taken what they've learned from patient experience surveys and tried to think through how can they redesign care? How can they redesign processes and policies? And what we've helped them understand is that they need to bring patients and families to those tables when they're looking at that data. They need to ask patients and families for their perspectives and their ideas on how to shift care delivery and really transform care so that they're not really just working in a vacuum, but they're taking into consideration those unique experiences and insights from patients and families. So that's just one example, and I have included on this slide other examples. I mean, there are a myriad of ways that organizations can partner with patients and families to transform care and to improve quality. These are just some examples, and they range from things like governance to quality to patient safety. But in our experience, the organizations that have experienced the greatest success with partnership have said that their achievements are attributable to the fact that they don't make any organizational changes. They don't undergo any design or redesign of policies or processes without collaborating with patients and families. So these are just some of the examples, and I included very briefly here some of the attributes for success. And I think many of you on today's webinar are going to be familiar with the kinds of things that are necessary to shift a culture or to transform an organization. And so you'll recognize these attributes. There are things like strong leadership, engaged staff, a culture that's really open to change and to embracing the belief that patients and families have these unique insights to share. It's a recognition that it's important to work with patients and families and not just do things for or to them. And also, really importantly, it's really essential to have a person within your healthcare organization who's responsible for advancing and for nurturing these partnerships with patients and families. So I will end by just saying that I've been working on consumer engagement issues for almost 10 years now, and this work has been incredibly gratifying. And I think it's because we're hearing directly within these 3 models that we're working with from patients and families, but also from healthcare staff and healthcare clinicians. They're telling us that these partnerships are beneficial. They make a difference. And many of the healthcare organizations are telling us that their only regret is that they hadn't begun to forge these partnerships sooner. So with that, I will now turn over the presentation to my colleague, Allison Shippey. Thank you.
Great. Let's see if I have control now. There we go. So thanks, Jennifer, and I want to offer my thanks again to PCPCC for inviting us all to present to you today. As noted earlier, my name is Allison Shippey, and I direct the partnership's quality measurement and value purchasing portfolio. There we go. Specifically, I work under a project called the Consumer Purchaser Alliance. Some of you may be familiar with our former name, and that was the Consumer Purchaser Disclosure Project. We are a team bridging 2 organizations, one of which is the National Partnership, and Deborah Ness, our president, serves as the project co-chair. And the other project co-chair is Bill Kramer, who is with the Pacific Business Group on Health. And that group many of you may be familiar with, works with employers, both large and small, on various healthcare activities. And there are a number of other staff in San Francisco out of that organization that also work on the project. Collectively, we're about a 7-member team. So the Consumer Purchaser Alliance is funded by the Robert Wood Johnson Foundation, and we have been operating for over 10 years. So, you know, we know that the U.S. healthcare system spends a great deal of money on healthcare, but nationally, we don't have great overall health outcomes, and the value for our healthcare dollars is fairly poor. So the Consumer Purchaser Alliance works in a number of different advocacy forums to try and advance a performance-based health system. We feel that transitioning to a system that pays for high-value, patient-centered care is critical to improving our system. Consumers and purchasers have a shared goal of improving health and healthcare. Patients want to be healthier and receive care in a coordinated, high-quality way, and purchasers or employers want their employees to be healthier, of course, so they can live full lives, so they can come to work and be productive. And purchasers always also want to make sure that they are spending their respective purchasing dollars appropriately. The Consumer Purchaser Alliance is not a membership organization by any means, but we do work very closely with a number of other consumer advocacy organizations, labor unions, and employer organizations, some of which I've listed on this slide. They include AARP, Consumers Union, Leapfrog Group, but we have almost 35 individual organizations that really are very highly engaged with our work, which primarily focuses on the larger measurement enterprise, and we engage with them via webinars and conference calls, in-person meetings, and et cetera. Let me make sure this is, there we go, there's a little bit of a delay. So this first slide, better use of measures. You know, a performance-based healthcare system is one that requires the use of standardized measures to consistently evaluate progress, comparing and benchmarking performance and identifying areas for improvement. Measures can also be used to inform consumers when making their respective decisions about treatments. And quality measures are now playing an ever-growing role in how providers and hospitals are paid. So we, as Consumer Purchaser Alliance staff, serve in a number of different capacities. We work very closely with those 35 and partner organizations to build consensus among consumer and purchasers. You know, we really kind of circle the wagons about tough issues that are before us and kind of moving the value proposition forward within healthcare. And we try to kind of catalyze or shape different stakeholder views on those particular positions. We do analyze kind of critical issues and engage constituents and opportunities to influence the scope and pace of measurement and public reporting and payment reform. And we also serve as an expert analyst. We have been seen within a number of communities as a central resource, particularly on a lot of the technical components on measurement. And consumers and purchasers look to us to provide detailed analysis of proposed measures and policies and regulations. And overall, we use all of those kinds of building blocks to better equip us and consumers and purchasers in general to be strong advocates. We want to make sure that consumers and purchasers have a very vigorous voice in shaping policies and programs that relate to how performance is measured. So One focus of our work this year is reflected in this slide in advancing better quality measures. The Consumer Purchaser Alliance, like many others, works to advance outcomes instead of process. We really want to drill down to things and evaluations that are looking at whether you're making a whole person healthier and increasing their functional status, improving their overall experience within the healthcare system, and moving away from process. And we do this by influencing comments to Medicare on their respective quality reporting programs. We also are heavily engaged in the activities of the National Quality Forum, which for those on the call who are not as familiar with that organization, it is a consensus-based organization here in Washington that brings together major healthcare stakeholders, so health plans, providers, hospitals, consumers, the research community and public health community. And we come together around a table to evaluate the strengths of various quality measures and how they can help further improved quality within our healthcare system. So targeted areas for our work within this kind of better quality measures umbrella includes moving the ball forward on measurement areas that are really critical to consumers and purchasers, things like patient-reported outcomes, where you have only the patient providing the information. There's no kind of translation needed from another healthcare provider or another staff member within the healthcare system. The patient is the source for that information. You know, whether their pain is managed appropriately or whether they're able to walk up a flight of stairs after a particular procedure. That kind of view as the patient as a hub of important information, as an indicator of how we as a health system are delivering care is really a critical topic area for consumers and purchasers to focus on. We also focus on, as noted on the slide, I think I skipped forward accidentally, sorry about that, maternity and cost and affordability. We also work closely with consumers and purchasers on how we can better leverage data resources like registries, because those are systems that are critically important to feeding into how we develop and how good the performance measures are that are out there in the system. So our next, our secondary focus within our work is, you know, once we have kind of a solid cadre of measures that we think really are focused on outcomes, how do we get those to be used? Used by federal partners, used by private payers, and how do we encourage kind of public reporting and information sharing with consumers? So that second arm of better use of measures, the majority of our work is really on the federal side of things. We try to influence federal strategies on a number of different kind of comment opportunities through proposed rules. Things like new models of care that Jennifer noted, how physicians and hospitals are transitioning into value-based purchasing and away from fee-for-service payment. I think a timely example of our work within that scope would be related to the currently out for public comment physician fee schedule. You know, we have a number of different quality reporting programs within that larger federal sphere, and one is the physician quality reporting system, and that's a clinician-level reporting program. So we're seeing that there are a number of low-bar process measures that have topped out in their performance. So we see that these are no longer meaningful measures to report publicly to consumers, and they're no longer leverage points, so we can improve care. So we would always work to reflect in our advocacy materials, you know, what is really moving us down the road in seeking high-value, high-quality care that is meaningful to consumers and purchasers, and measurement in ways that can be used to improve care and lower costs. Another way that our team works to influence the use of better measures is in a pre-rulemaking process called the Measures Application Partnership. Among other things, there are certainly other committees and work groups that provide meaningful comments and input to federal partners on what measures are most meaningful in different reporting programs and at different levels. We work to ensure that consumers and purchasers are key voices on those different work groups. So in summary, the Consumer Purchaser Alliance really does envision a future in which we have meaningful and useful measures of performance, so clinical and patient-reported outcomes, like I had noted before, that we have coordinated care across the health system, that our health system reflects an affordable environment and one that values the patient experience. And all of those measures wrapped together would be used by consumers to make informed choices about their health care, by purchasers to make good decisions about the health benefits they offer, and by physicians, hospitals, and other healthcare providers to continuously improve the care that is delivered. And I think in that, I will transition over to Mark.
Thanks, Allison. So I will cover a little bit about the work of the National Partnership on leveraging health information technology for care delivery transformation. Before 2009, there had been some degree of health information technology development going on in pockets, but the nation needed far better progress to meet the triple aim of better care, better health, and lower costs. And so in 2009, Congress passed the HITECH Act as part of the American Recovery and Reinvestment Act, which is the federal stimulus bill. And the HITECH Act undertook to build the backbone and infrastructure of delivery reform, payment reform, and quality reform across America. Being a stimulus bill, it set aside an estimated $27 billion over 10 years for electronic health information technology and exchange, largely as incentives to doctors and hospitals to purchase electronic health records. The Act leveraged the federal role as the largest payer for health care through Medicare and Medicaid and made those payments, those incentive payments, available to Medicare and Medicaid providers. But the assumption and hope was that if a doctor or hospital is providing electronic health information to Medicare and Medicaid patients, that the hospital or the doctor would be making that available to all patients, whether or not they were on Medicare or Medicaid. And perhaps most interesting, Congress's stated goal was that by 2014, this year, doctors and hospitals would be using an electronic health record for every person in the United States. That's quite an ambitious goal. We're not there yet, but it illustrates the notion that we needed to make far quicker progress than we had been doing to date. The HITECH Act recognized that the technology itself was not the end in itself, but rather it was the meaningful use of health information technology that was necessary to improve care and health. So Congress and the relevant health agencies employed, and they are currently employing, a phased approach over about 6 to 10 years, because we cannot transform the nation's health information infrastructure on a dime. So there are 3 stages that you see on the graphic in front of you. In order to sort of build this in a progressive approach, in stage 1, the agencies have focused on basic data collection and use with some limited patient access to information. Stage 2 builds upon that and focuses on more robust data collection some information exchange between doctors and hospitals, and some care coordination with other providers, and even better online access for patients. The thought was that building upon stages 1, stages 2, with stage 3, we could actually focus not on the processes so much that are in stages 1 and 2, but we could actually shift to improving outcomes, quality, and health. There we go. So this slide lists some of the examples of meaningful use criteria that have been developed and have evolved in the regulatory process. And you'll notice I've highlighted in red on each one of those 3 buckets of stage 1, stage 2, and stage 3 some of the patient-facing uses that the National Partnership and the Consumer Partnership for eHealth and other patient advocates, hopefully many of you on the phone, have worked so hard to include in order to position patients and families as partners in care. You'll see from this overview that with sustained advocacy, we have been able to get more and more significant items included with each stage. So at the beginning, again, sort of just a basic visit summary in stage 1. But in stage 2, where we are now, the capacity for patients to view their own information online, to stage 3, which does include the online access, but actually patients can upload and contribute some of their own health data to the electronic health record. And so with the limited time that I've got, I just wanted to illustrate with 4 quick examples some of these meaningful use criteria in order to transform to patient-centered care. The first is getting patients ready access to their health information. Now, believe it or not, under HIPAA, or the Health Insurance Portability and Accountability Act, doctors could take from 30 to 90 days to get you a copy of your health information, whether in a paper or an electronic form. And I confess that continues to surprise me since we're in the 21st century. The National Partnership recently conducted a nationally representative survey where we asked patients about the importance of online access to them. Not surprisingly, and we divided them into 2 groups, respondents whose doctors were using patient records and respondents who knew that their doctors were using electronic health records. So for the respondents whose doctors were using paper records, not surprisingly, nearly 2/3 wanted online access now. And even more Hispanic adults in paper systems wanted that online access. Shifting over to the group that already had online access and their doctors were using electronic health records, 80% were using it. So this is about the kind of patient-centered care transformation that we're trying to build. And those patients with the online access were more likely to find that the electronic health record was useful to them personally and key elements of care, that it was having a positive impact on the quality of care. They could see that it was more useful to their doctors, and they actually trusted their provider more to protect their rights. So knowing that, the National Partnership and other advocates worked within the regulatory process to try to build online access into the Meaningful Use program, and we were successful. And what I've sketched here is a brief description of what that criterion is. Perhaps all the details are not quite so important as to just understand the overall fact that patients now, within 24 hours, are supposed to be able to get online access to the health information in the doctor's electronic health record, not to wait 30 to 90 days for that access. And it covers the range of health data that you see at the bottom there. The second example is often called patient-generated health data. patients have always been a very important source of health information. So we worked to build in systemic ways for patients to be partners in contributing their data to their health records. The consumer, forgive me, I don't know what's going on there. The Consumer Empowerment Work Group held a series of hearings in 2013 on patient-generated health data in order to build in a patient perspective on the importance of that data and contributing it to the electronic health records. After hearing from a variety of folks, they came up with this definition that patient-generated health data are health-related data, including health history, symptoms, biometric data, that would be the kind of data that you might get from a medical device, treatment history, lifestyle choices, even environmental factors, and that these are coming from patients or their designees, which might be other care partners in the family, for example, that are designed to help address a health concern. And the hearings made it quite clear that even though we were talking about it as a new factor for the program, patient-generated health data are not new. Doctors have been relying on family history information from the patient for a very long time. So this was the foundation for trying to build in the requirement into our advocacy. This slide shows the results to date of the effort. This is a recommendation from the Health IT Policy Committee that we hope will be included in Stage 3. And it's a recognition that electronic health records should enable providers to receive, review, respond, and record patient-generated health data. So no longer do we have this one-directional source of information. We are now trying to build in patients as equal partners in contributing information to their care, to their record. Now, doctors, of course, will have to review that information for relevance and to understand where it best fits. But now you have, again, leveraging health IT for partnership in care delivery. Regarding the third example, the National Partnership and others have emphasized that health information technology must reflect and accommodate the diversity of patient populations across the country. And on this slide, you'll see some of that diversity reflected. For present purposes, I just want to focus on the one in the lower left-hand corner, which is language access. It won't surprise many of you on the phone to hear that 1/5 of the nation's population speaks a language other than English in their home. And so if we're talking about access to information, if we're talking about access to prescription labels, to hospital discharge instructions, and all of that important health information is not available in the language that the patient speaks, we have problems. So the National Partnership and others have urged that we include language access, that we build it into the system from the very beginning. We haven't been able to accomplish everything that we wanted on this criterion, but here's what we have been able to accomplish. We did persuade them that they should build in access in at least one language for patient educational materials. So this is not across the board in all ways that patients might access health information technology, but at least with the respect to educational materials that are provided to the patient. This, at least, is an important first step because in requiring electronic health records to be able to do this for one part, we have begun to move electronic health records in the process towards building that access for all parts. Last example lifts up the critical importance of care planning and a patient and family-centered approach to health and care planning. Lots of work has gone into here at the National Partnership with the Consumer Partnership for eHealth into asking patients and family caregivers what they want, and I could actually devote a full hour to just describing that process. For today's purpose, I just want to jump to the result of what patient and families and their caregivers told us they wanted out of a patient and family-centered health and care planning process. What you see on the slide in front of you is the consensus definition, a multidimensional, person-centered health and care planning process facilitated by a dynamic electronic platform that connects individuals, their family and personal caregivers, paid caregivers, and healthcare and social service providers as appropriate. And here's what we have been able to get in to the Meaningful Use program so far. The important thing is there in the middle. There have been transfers of care for a long time, but now, with Stage 3, transfers of care are supposed to include the patient's goals. That's the goals as the patient articulates them, not just the clinical goals as the doctor or hospital might articulate them. Some information about the patient's designated caregivers, so not just information about doctors, specialists, hospitals, but information as well about key people in the patient's home or elsewhere that the patient uses to help provide care. Also, instructions for the patient. So again, this is not a complete electronic platform that provides patients and families with all that they might wish for their health and care planning processes, but it is an important start, and it reflects our advocacy to get those who are building the system to begin thinking about the role of patients and families in transforming their own care. Obviously, in these 4 examples, much remains to be done to meet patients' needs, but I just wanted to illustrate some of the ways that we have been able to leverage health IT to help patients and families be true partners in their care and health. And as Jen said at the beginning, here's a slide for when you want to, if you want to reach out to us and contact us further. Thank you so very much.
Well, this is Amy, and I just want to thank you all for an incredible presentation. It's so impressive, all the work and the depth of the work that you're doing at the National Partnership to get the patient's voice and the patient's priorities really integrated into everything that we're trying to accomplish in terms of healthcare reform. So kudos to all that you're doing. Just a quick reminder for those of you who do have questions, we don't have the ability for you to do a live audio ask, but we allow for you to ask your questions through the chat function or the question box on your dashboard. So you should see on your screen a little box to type in your questions, and if you want to go ahead and start queuing those up, we've got a few in there already that I'll be asking our presenters, but feel free to go ahead and type away and ask those questions. And again, please do take them up on their offer if you have more specific questions that you'd like to ask using their contact information that's up on your screen. So Jen, I'm going to pitch it to you first. I think I'm going to ask the question that might be kind of obvious, and people on the call might be thinking, oh, well, it totally makes sense to all of us. Of course you should involve patients and families in quality improvement and improving the overall healthcare system and working it directly with practitioners on how to make the care better because they utilize the care. But not every single health professional is doing that. We know that across the board in large integrated health systems and individual practices, you know, you mentioned that the one thing that you hear from practices who do this work and involve patients, they say, gosh, why didn't I do this right from the beginning? Why didn't I start doing this sooner? So what do you think? Why aren't they doing it? Why aren't they all across the board engaging patients in this way? What are their perceived barriers or challenges to making that happen?
Thank you, Amy, for that question. I will say first that I do think that there is a growing number of healthcare organizations that are beginning to engage patients and families as partners in care, in delivery, in redesign. So we are seeing an uptick in this work, and I think it's great. I mean, it's a real opportunity to help share lessons learned and to help folks who may not recognize the importance of this work, you know, sort of begin to adopt it. In terms of, so that's the good news. In terms of the barriers, I think some of the barriers that we have heard And some of them, frankly, are not necessarily borne out. I think they're more fears than barriers, are things like, engaging or partnering with patients and families takes too much time. So, for example, one of the things that we work on with some of the hospitals that we partner with is doing rounds at the bedside with patients and families. And there's been some good data that shows that it helps patients and families better understand the kinds of care that they're getting. It helps with quality and outcomes. But I think there's a sense among healthcare providers that actually, doing rounds at the bedside with patients and families versus out in the hallway will take more time. And we all know that time is a real factor in healthcare. And actually, what has been shown is that it doesn't take more time. It takes a skill in terms of being able to communicate effectively with patients and families, but it ends up reducing a lot of rework that needs to be done, usually on the part of nurses, with patients and families to make sure that they understand the information. So the time factor, I think, is probably more of a fear than a barrier. The other thing that we will hear from folks is, it takes a lot of resources to do this work. And I will not deny that it does require a point person in a practice, at an ACO, or within a hospital who can take responsibility and be accountable for advancing patient and family-centered care and building these partnerships. So yes, it does require some initial resources. But I think those resources, there's an incredible return on investment because, again, as I said, what these facilities find is that with these partnerships, they are reducing their overall costs. They are improving their quality and outcomes. In some cases, they're reducing their costs associated with medical malpractice. They are retaining staff at higher rates. And I think most importantly, not only are patients experiencing care in more positive ways, but clinicians and staff report a greater satisfaction in their work. So there's, less turnover among staff and clinicians. So I think, we have to make sure that we're keeping in mind that some of these barriers are fears and that they're not always borne out, and in fact, there's a return on investment of doing this work.
That's great, Jen. Thanks so much for that. So, Mark, I have a question for you. So, really impressive everything that you talked about in terms of really making sure that from a technology standpoint that it's working better for patients and patients have access to their data. You talked a little bit about patient-generated health data. And we know that with all the new apps that are out there, all this technology that's available now, things on the web, things on our phone, patients already are collecting a lot of data and collecting a lot of information about their health. What are the conversations or the concerns that you're hearing from patients about how they might be able to transmit that data into when they go to see their doctor, or how do we better integrate a lot of this information that's being collected at various places? We still hear from patients that that's often a barrier. They might have access to health information through their cardiologist, and then when they go to see their nephrologist, it's a different system, and they have to log in a different way. What are some of the things that the National Partnership is doing to address some of those concerns, if you're hearing those as well?
Well, we are, and here, sort of patients generating their own data with apps or devices and trying to contribute them. The biggest barrier is that doctors haven't been used to receiving information electronically that way. They're still trying to transition to electronic health information technology in the first place. So it has been actually a surprisingly good round of advocacy to try to get just this basic criterion built into the system. Our hope is that as we start, that doctors will realize how useful this is to them and that things will improve. I think the short answer is that it's going to be a little slow at the beginning, so it's not completely accomplished, even though we all recognize the need. And we're just trying to build it in. As doctors become accustomed to doing that, accustomed to receiving it, things should become better.
Great. And Mark, while I got you, I got a question here from Suzanne, and she's asking about the language piece. So she says there's still a real concern that information isn't available electronically to patients in Spanish. Do you have any sense of kind of what's going on from a national perspective on progress on that front and in kind of tearing down some of those language barriers and helping with the health literacy issues?
That has been an issue that's been particularly dear to my heart. I was recently in California. I watched what happened in the state of California's demographics when they built an ATM system, and it was only available in English. And they had to go back and they had to rebuild it. And so when I ask questions of the national coordinator, when I speak at presentations, I always lift up the issue of language access because we should surely be able to build the system right the first time. That said, currently electronic health records are not being built with language access throughout, and that's unfortunate. We are trying to build in what we can, and so I'm grateful that we are getting at least access to patient educational materials in language. I think that as we build upon that experience, both doctors and patients will see more and more how critical that is. The demand will increase because now it's becoming available. Hopefully we'll see much faster progress in the 3 to 4 years to come than we've seen to date.
Great, thanks. Well, I think we've got time for just one more question. I apologize to all of you who've been participating if we don't get to your question. Again, do reach out to all of our speakers using their contact information, and I know they would be more than happy to answer your specific question. But just to kind of wrap things up, we got a question asking, what do you find right now most surprising about what you're seeing in the healthcare industry as it relates to involving patients and families? Amber says you can mention something that's either positive or negative. So what's something that you're really seeing that's very timely, that's happening right now, that's exciting or worrisome?
Jen, you want to start?
Sure. I think I sort of alluded to this a little bit earlier when I said that there's been an uptick in organizations interested in partnering with patients and families. I'll be honest that when I first started doing this work 10 years ago, I think there really was more of a deer in the headlights look when I mentioned the importance of working with patients and families to improve care, and there really wasn't as much receptivity to doing that. So the fact that we're having organizations contacting us and saying, you know, we agree that this is a real promising strategy and we'd like your help to do it, I think is really a great positive shift.
Yeah, I really do agree with you, Jen. I think that it's really, you know, I've heard people even coin the saying, you know, oh, it's the year of the patient. I think you're right. I think now is finally the time has come where people really are recognizing how critically important that is to transforming our overall healthcare system, and it certainly is exciting from our vantage point here at the PCPCC, and certainly working with all of you to ensure that that happens even faster and more profusely than it has in the past. So we are at the top of the hour. I want to thank everyone so much, especially our guests. Thanks, Jen, Allison, Mark, for your great presentations. We will again have this available up on our website by the end of the day tomorrow, so please do forward the link to your colleagues and anyone else who wasn't able to participate live with us today. If you're not already receiving our communications, you can also log on to our website to receive our monthly newsletters and information about future webinars that are coming up, and of course lots of other activities and resources that are available on the PCPCC website. So thanks again to all of you, and enjoy the rest of your day.